This is the board review preparation presentation on the topic of elbow arthritis. As many of you know, I present one of these resident lectures every year, and in fact, I believe I have another one of these coming up in a couple of weeks. I've modified that presentation and added some questions to illustrate some of the points I'm going to try to make, and hopefully this will be quite helpful for you guys as well. So just to review the anatomy of the elbow joint, the main point here is just to illustrate the fact that the center of rotation around the elbow joint goes through the lateral epicondyle, but does not go through the medial epicondyle. In fact, the center of rotation on the medial side of the elbow is just anterior and distal to the medial epicondyle, so that has to be understood. The rest of the anatomy is pretty straightforward, and I'm sure this is a review for you, but just to make sure, I am providing this picture as a guideline for you to review in the future if you need it. Same thing with the distal humerus. Alright, so let's start actually talking about the elbow arthritis. As you know, the elbow actually contains three separate joints. It's not only the ulnar humeral or the radiocapitalar, there's also a radio-ulnar joint that you have to understand. And sometimes the questions will be specific to make sure that you understand that there is a third joint that has to be treated. Distinct causes of arthritis include osteoarthritis, which is increasing, mainly because I think there's more people that are working out and using the arm for heavy lifting. Inflammatory arthritis rates have been going down, mainly because of the disease-modifying drugs that are available for patients with rheumatoid arthritis. Post-traumatic arthritis is probably staying around the same. Various treatment options that we're going to discuss on this presentation will be arthroscopy, arthrodesis, resurfacing, and arthroplasty. When a patient presents to your office, you're going to have to understand exactly what the symptoms are. Obviously, the most common complaint will be pain. In addition, they may complain of weakness, contracture, intermittent locking about the joint, as well as some decrease in functional capacity. In terms of pain, I also want to stress to you that you have to understand whether the pain is occurring at mid-motion or only at extremes of motion, because they're going to be treated separately and with different methods. If the patient had pain at mid-motion, then you're talking about arthritic changes with minimal cartilage in the articulating surface. If patients only have pain at extremes of motion, that likely means that the joint is okay, but that they have osteophytes that are pinching and impinging against each other, causing pain. In terms of examination, once again, you're going to confirm their motion, both active and passive, as well as understanding whether or not their pain is from during mid-motion or at extremes of motion only. You also want to confirm their strength as well as any possible deformity around the joint. In terms of motion, I wrote down these numbers of a flexion extension arc of 30 to 130, as well as pronation supination arc of 50 to 50. These are numbers that were obtained from a study that was done back in the 80s that are looking at the functional capacity. So if you have these 100 degrees of arc, in flexion and extension, as well as in pronation and supination, your functional capacity should be reasonably maintained. However, there have been some more recent studies that were performed looking at the functional capacity and the motion that's required from the elbow. With the use of cell phone, you need a lot more elbow flexion because you're holding the phone against your ear. And obviously, if you're going to be using the keyboard a lot, as most of us are, then you're going to need a lot more pronation. So you're going to have to remember those things as well. In terms of imaging, plain radiographs are generally sufficient. Obviously, if the patients have a lot of arthritic changes with heterotopic bone or osteophyte, CT scans, especially CT scans with 3D reconstruction would be quite helpful. If there's any concerns about the soft tissue, you could also get an MRI, but this is probably not that helpful. Ultrasound really has minimal role, and I haven't really seen much use of it described either in the literature or in any clinical practice. General guidelines in terms of treatment include non-operative treatment whenever possible. Unfortunately, as most of you know, non-operative treatment for elbow arthritis don't really work all that well. I am going to keep bringing up this point, which is that you do want to distinguish what you're treating. Oftentimes, you're going to have to treat either the pain or the motion of the elbow primarily. So you really do want to speak with the patient and understand their primary complaint, whether it is pain or motion. Remember, you are treating their symptoms. You're not treating only their x-ray presentations or what their elbow may look like in the future. Okay, so that brings us to our first sample question. Figures 1 and 2 show plain radiographs of an elbow of a 48-year-old man. He has a 3-year history of numbness and tingling in the ring and small finger and a stamping sensation to his medial elbow. So this is a guy with ulnar neuropathy with subluxating nerve. On physical examination, his range of motion is 0 to 130 with full forearm rotation. He has a positive flexion compression test and Tinel sign over the elbow. What is the best treatment option for this problem? This is what his x-rays look like. You can see that he does have some arthritis with osteophytes as well as most likely some loose bodies. And clearly you can see some loose bodies right here on the anterior aspect of the coronoid fossa. All right, so going back, so the guy has a degree of arthritis with likely loose bodies and some osteophytes. However, his range of motion around the elbow is pretty good, and he doesn't seem to have a lot of pain, right? So let's take a look at it. Arthroscopic removal of loose bodies. He doesn't complain of any numbness. He doesn't complain of any intermittent locking, so I don't know if this is necessary. Manipulation, his motion is good, so that's not going to require cubital tunnel release. This makes sense. He has a lot of ulnar nerve symptoms with subluxating nerve. Open reduction internal fixation of a non-union. Clearly that's not going to be the case because he doesn't have a fractured non-union. He just has an osteophyte or loose body in that area. So the best answer is probably cubital tunnel. I think they're trying to illustrate the point that the patient may show x-ray findings of an arthritis, but that his symptoms from arthritis are very minimal, that his only symptomatic pathology is the ulnar nerve. All right, so let's start talking about treatment options. Non-operative treatment, as I mentioned, is generally not all that effective. Obviously, you could tell the patients to rest and modify their activities and take some anti-inflammatories to control the pain as best as possible. If the pain is quite severe and acutely deteriorated, you could consider cortisone injection. You could also consider supervised therapy, but this is going to be treating only emotion, really. You're not going to be making the patient's pain much better with physical therapy. So you do have to understand, once again, what they're asking for. Orthosis probably is not going to be all that helpful. If the patient has some subluxating sensation and they feel like the elbow is really quite painful during these episodes, you could consider an orthosis, but that's going to be pretty rare. In terms of surgical treatments, there are several, and the first one that we're going to be discussing is elbow arthroscopy. General principles around the arthroscopy is that this would be ideal for patients whose joint space is reasonably maintained. So you see a patient here where the joint space is actually maintained, but they're going to have pain at extremes of motion, at extreme flexion and extension, because the osteophyte about the coronoid process is going to impinge against the osteophyte on the anterior coronoid fossa at terminal flexion, and similar thing is happening on the olecranon fossa as well. So if you remove these osteophytes, the patients are going to feel a lot better and they have less pain. By removing the osteophytes as well as get rid of some of the contracture, the patients may also see some improvement in their motion. However, the improvement in motion is not quite as predictable. Arthroscopy performed in the supine position or with a patient in prone position. Most commonly, and with most of the members of our department, the arthroscopy is performed with a patient in the lateral position in a beanbag and a post to hold the arm up. You have to understand, however, when you're putting the post up, that it does not impinge against the anterior part of the antecubital fossa, because you want the anterior capsule to be distended away from the joint in order to access the anterior compartment. So positioning is quite important in being able to perform this procedure. This is a diagram that illustrates various portals around the elbow for arthroscopy, as I mentioned to you before, and I actually don't remember all the specific names. The important ones to know is that you want to avoid posterior medial part of the joint where the ulnar nerve goes in. The major portal is anterior medial portal. This is the initial portal to introduce the arthroscope into the anterior compartment. Anterior lateral portal is the other working portal. Posteriorly, you're going to look at the straight central portal and the posterior lateral portal. What you have to understand, and this question will be asked quite often, is the ulnar nerve can be injured if the nerve tends to subluxate or if it is transposed anteriorly. Generally, the question will be framed such that the ulnar nerve has been transposed. If it is subluxating, you can still do arthroscopy. You just have to be a lot more careful. As I mentioned before, after arthroscopy and removing all the osteophytes, patients do have a predictable relief of pain. Their improvement in motion, however, will not be predictable. So some patients will get a lot more motion. Some patients, unfortunately, will only get a little motion. So you have to tell the patients about this finding before the surgery. In order to improve the motion after surgery, you do want to initiate early motion exercises. Some of the reports have advocated the use of aggressive CPM as an inpatient. However, given the insurance situation, that may be difficult, certainly in New York, and most likely they're not going to ask that as a question. Some surgeons also utilize using splints, whether it be dynamic splinting or nighttime splinting, to maximize the motion that they could contain. All right, so this brings us to our next sample question. So an obese 47-year-old woman with diabetes experiencing gradual stiffness and pain about the elbow. Her orthopedic history is significant for bilateral ulnar nerve transposition. Ding, ding, ding. So ulnar nerve has been transposed, which means you cannot do, at least not safely, you cannot do elbow arthroscopy. An examination reveals approximately 45 degrees of loss of motion and about 20 degree loss of both pronation and supination on the right elbow. Her radiographs reveal moderate arthritis, best treatment options. So she is 47, so total elbow replacement probably will be a little too aggressive. So options include injection of another set of steroids, which would be okay, but it's gradually worsening and not acutely deteriorating. So that's probably not going to have a huge impact. Plasma-rich plasma, PRP, no role that I know of. Arthroscopic contraction relief. Once again, ulnar nerve has been transposed, so you can't do that. And in fact, I think that's the main point that this question is trying to test. Open contraction relief. So by default, that's probably the right option. Next sample question. Okay, so 45-year-old laborer has pain and stiffness in the right elbow, which has gradually worsened. He has several injections with diminishing success and is now taking narcotic medications. He is still working despite the pain and reports that he cannot take much time off work or he loses his job. Examination revealed full strength, but extension to 30, flexion to 120, pronation to 90 and supination to 85, so their forearm rotation is maintained. He has mild crepitus with motion. X-rays reveal moderate arthritis in the humerus and ulna. His radiocapitalis joint has minimal arthritic changes, so basically don't worry about the forearm rotation. What is the best treatment option? Option A, narcotic pain medications for NSAIDs. That's probably not going to do much. Injection with steroids. Once again, he's already had those. That's not going to have much of a difference. Arthroscopic fenestration of the fossa of the olecranon and osteophyte debridement. That makes sense. You probably take care of both anteriorly and posteriorly. However, given the fact that he has mostly an extension issue, a lot of the work will be done in the back of the elbow. Open debridement, that may also work. Osteophytes on the humerus and ulna with radial head resection. So that's where this is a bad option, right? His radial ulnar joint is good, so there's no reason to address or do anything with the radial head. Number 5, total elbow, or E. Total elbow would be too aggressive on a 45-year-old laborer, so the best option here would be the arthroscopic debridement or osteocapsulectomy. Next topic or next treatment option is arthrodesis about the elbow. This is very rare, and in fact, it's so rare that I never done one of these. And in fact, it's so rare that it is very unlikely to come up as a test question. However, obviously, for completeness sake, we should discuss it briefly. You're going to basically reserve this for patients with that has a high demand and possibly with infection that you just can't get rid of. The procedure is associated with fairly good and predictable relief of pain. However, the functional use of the arm is going to be quite compromised because you can't move that elbow and you can't not place the hand where you need to place it. What we also don't know is what is optimal position for fusion. That'll depend on each individual. One of the tricks that a surgeon has taught me in the past is to cast the patient in a long arm cast in varying degrees of flexion, so in 30 degrees, 90 degrees, and 120 degrees, and to see which of those recasting position was the most optimal, and then proceed with surgery like that. This is a case that was given to me by one of our previous fellows, who was with us about a decade ago. He was serving in Iraq War after his residency, so this is before fellowship. He had a patient who showed up with a blown up elbow, and he didn't really know what to do, so he went with an arthrodesis. He also doesn't have any follow-up because during the Iraq War, apparently there's minimal follow-up on any of these patients. The next topic on the treatment options for patients with elbow arthritis is resurfacing. We're talking about biologic arthroplasty with some kind of an allograft, usually Achilles tendon allograft that acts as an interposition between the distal humerus and the ulna. We're going to do this essentially for patients with end-stage arthritis who has a lot of pain in mid-motion. In fact, you're talking about patients who need an elbow replacement but are just too young to get it. We have to remember, and this has been asked in various test questions in the past, that the joint stability and biomechanics has to be maintained and intact from the native structures only. So if the joint was unstable before and you put a biologic resurfacing, the joint is going to still remain unstable, and they're going to do poorly. You could do this with a little distraction to protect the interposition graft initially, and you do that by applying a hinge external fixator. The overall success rate is okay, so about 25 to 50% failure rate depending on who you ask. What we also don't know is, unfortunately, the durability of the construct may not be that great, but obviously you're trying to buy them time until they need a total elbow replacement. Patients with inflammatory arthritis seems to have a little inferior results. My guess is that patients with inflammatory arthritis also have some issues with their ligaments, and such that their joint stability is not all that well maintained. This is a diagram. I've only done this procedure twice, and I did not take any pictures. But this illustrates the point. Basically taking an allograft, a biological allograft, and basically resurfacing the distal humerus. So sample question on resurfacing. So figures 1 and 2 are radiographs of a 46-year-old woman with a 10-year history of elbow pain associated with stiffness. He previously underwent ligament reconstruction. He has pain throughout his range of motion, which goes from 20 to 80. Initial treatments have failed, including arthroscopic debridement. What is the most appropriate treatment? So obviously arthroscopy has failed, and this is what his x-rays look like. So his end-stage arthritis most likely has a lot of pain in mid-motion. His range of motion is also deteriorated as well. So non-constrained total elbow, that is something that you could consider, but you have to understand he's 46, so that may be a little difficult. Distal humerus replacement arthroplasty. He has arthritis everywhere, including the ulna, so this is probably not going to work all that well. Arthroscopic release. This has already been performed with minimal improvement. So given his age, most likely option and probably the best treatment option is soft tissue interposition arthroplasty with an Achilles tendon allograft. All right, the next sample question. A 41-year-old right dominant man with arthritis. He's been treated with activity modifications, medications, therapy, and multiple injections without improvement. He is now considering surgical treatment for soft tissue interposition arthroplasty with Achilles tendon allograft. What pre-surgical finding correlates with elevated risk of post-surgical complication? Inflammatory elbow arthritis, that is one of them, although it's not a direct correlation as much as that possible instability issue. So that's an option. A pre-surgical flexion extension arc of only 50 degrees, that is probably not much of a complication risk. Retained distal humerus hardware, once again, I don't think that really elevates the risk as much. Evidence of pre-surgical elbow instability, that definitely is a risk factor. In fact, that may be a contraindication. So between option 1 and 4, option 4 is a more direct answer. So I would pick option 4 on this one. The next and the primary treatment for patients with elbow arthritis is arthroplasty, so replacement. General principles, now we're talking about patients who have pain at mid-motion, so their joint is destroyed. It is associated with a significant postoperative restriction. So a patient with a total elbow replacement, you tell the patient they can't really push, pull, or lift anything objects greater than about 4 to 5 pounds. My restriction is actually only 2 pounds, so you got to be quite careful. This becomes more of an issue actually for older patients that have to use the arm for various weight bearing for ambulation, whether they're using a cane or a walker. That becomes more of a problem. So you have to appropriately counsel the patient. We also don't know how long these prostheses last, so that is a sort of a restriction in terms of putting them in patients that are too young. Options of arthroplasty include a partial replacement, whether it be just distal humerus or just a radial head or the capitellum. And then in terms of total elbow replacement, there are 3 options, well, essentially 2: constrained, which is not used anymore, unconstrained, and semi-constrained. So we'll talk about all of these separately. So partial replacement, let's just talk about the radiocapitellar joint. There is a partial distal humerus replacement only, but those really have not been used very widely and probably will not be on any questions. So in terms of partial replacement on the radiocapitellar joint, we're talking about treating patients with end-stage arthritis or possible deformity. Unfortunately, there's not a whole lot of clinical experience on either replacing the radial head only or capitellum only or a combination of both. So the indications for which patients would be ideal for this is still evolving. And because of that, I really doubt that you're going to get any questions on this. So this is one of my previous cases for capitellar replacement. This is about 40-something-year-old lady who presented to my office after suffering a fall and injury to the elbow. She was actually seen and treated at an outside hospital with some type of ORIF. However, she continued to complain of significant pain and weakness as well as stiffness. So the CT scan clearly illustrates the point further. So this is a patient whose capitellum had been broken and flipped anteriorly and clearly blocking motion in terms of flexion. So my options here were to do a revision ORIF and try to see if that capitellar fragment is salvageable, which it actually was not. Another option was just to resect it, but the joint was a little bit unstable at that point. So I decided to proceed with the isolated capitellar replacement. I think the patient did okay, at least in the beginning, but then she stopped following up, so I actually don't know what her long-term outcome is. Next treatment option, this is mainly for historical purposes only, which is a constrained elbow arthroplasty. So constrained means that you only allow movement in one degree of freedom, which is a hinge. However, as you know, there is a significant amount of valgus varus movement as well as axial rotation around the elbow joint. That is not counted for on this prosthesis. Because of that, there's a significant load that's been transmitted to the cement bone interface and significant amount of loosening has been observed. Because of that, this is essentially abandoned and it's not really used anymore. In fact, if you see any test questions where one of the options is a constrained arthroplasty, that is an immediate sign to eliminate that answer as a possibility. So the literature is obviously a little bit older here, but basically even at 3 years of follow-up or 3.5 years, your complication rate going in about at least 50% with significant amount of loosening and revision. So once again, this constrained arthroplasty is no longer used. So you should essentially always rule this out as an option for a test. Unconstrained, it is still used and is quite popular depending on the area of the world that you are practicing. Basically, it's an unlinked arthroplasty. So you do a distal humerus replacement and then proximal ulna replacement separately, and you let them interact with each other using native ligaments of the elbow. So the joint has to be stable and the biomechanics has to be maintained, similar to what we saw before with elbow resurfacing. So because the joint stability and the biomechanics has to be maintained, you have to do this surgery very, very carefully with meticulous techniques. It has been used primarily for patients with inflammatory arthritis, but only with patients with inflammatory arthritis whose joint is still reasonably well maintained. It is not really indicated for anything else, including fractures or deformity. If done appropriately, this is associated with significant improved outcomes, which are mostly rated to be good to excellent. These are some of the popular ones that were available about 5 to 10 years ago. I don't know if there has been a lot of progress on these, but these are the popular types. Overall results ones are pretty good. Majority of these have been performed, like I said, for patients with rheumatoid arthritis. So follow-up anywhere from 5 to 10 years with only about 5% revision. So basically, majority of these patients generally do pretty well. The most common replacement option is a semi-constraint. That is to say, the distal humerus and the ulnar components are linked with a pin. The joint is stabilized by the native ligaments, but also within the prosthesis because the components are linked. It is widely applicable and surgically more forgiving because even if your native ligaments are incompetent or perhaps cut during the surgery, once again, as mentioned before, the components are linked with a pin. However, the pin is not very constricted, so you also allow, the prosthesis allow about 5 to 10 degrees of varus valgus as well as axial rotation and allow the elbow to move in a more natural way. The overall results have been pretty good. These are older literature. There's a lot more recent literature that's out that I probably do need to summarize. But basically, good follow-up up to about 10 years with a really low revision rates as well as loosening rates. So majority of patients are doing pretty well with this operation. So an example here is a patient of mine with end-stage arthritis, clearly is deformed. In a case like this, there's no way I'd be able to put in an unlinked prosthesis. Plus, I'm just not that good surgically, so I always put in a semi-linked. So this is what the prosthesis looks like. The patients have done well. So sample question on this one. Figures show radiographs of a 75-year-old woman with rheumatoid arthritis who is experiencing pain that's refractory to treatment for 6 months. Optimal treatments include, okay, the x-rays look like this. So this is a very deformed elbow. In fact, it looks very similar to the case that I just presented, right? So clearly end-stage arthritis, a little deformity. And I'd be willing to bet a lot of the ligaments are not really working all that well. Okay, so let's take a look at it. Cast immobilization, that's not going to do much. Resection arthroplasty probably will provide some improvement or pain, but her functional use will be quite limited. Linked total elbow arthroplasty, that's probably my choice. Unlinked, you can perform that, but I'd be concerned given the fact that she has a significant deformity. I don't think the native biomechanics is maintained. Open induction internal fixation of a non-union. She doesn't really have a non-union, so that's not an option. So in this option between the linked and unlinked, linked would be a better option for me because the joint is quite deformed. So linked total elbow arthroplasty. Next sample question. 82-year-old woman sustains a comminuted intra-articular fracture of the non-dominant right distal humerus. When attempting ORIF of the distal humerus, which intervention should be avoided in the event of repair is deemed impossible and total elbow is required? Well, so the answer is olecranon osteotomy. If the osteotomy is performed on the olecranon, you don't have enough bone to support a ulnar prosthesis. So olecranon osteotomy has to be avoided. So ulnar neurotransmission doesn't matter. Posterior approach is going to be what we normally would do. Tricep splitting, you could do that in many different ways. Addition of a plate on the medial part, unless the screws get in the way, that's probably not going to be really much of an issue. So olecranon osteotomy is the final answer. Although elbow replacements can work quite well in the majority of the patients, it is associated with a significant number of complications. This is just a small list of complications, including loosening, osteolysis, as well as wound problems early after surgery. Fractures, injury to the nerves around the elbow, as well as triceps insufficiency, which is going to be the most common complication probably, as well as bushing wear. So these are all things that are very, very common, and you have to be able to address all these individually. So sample question on the complications. A 66-year-old woman with rheumatoid arthritis underwent total elbow arthroplasty with triceps reflecting approach. So triceps reflecting is the Brian Morey approach where you take the triceps and basically release it in continuity off the proximal ulna. But the triceps is actually moved away. You do the replacement and put back on to the ulna. Now, which immediate post-surgical therapy most likely will injure the repaired elbow? So we're basically talking about how do you protect the triceps tendon, right? Sling, that will protect the elbow, although it's going to be too stiff. Long arm cast, same idea. Prone extension against gravity. So this would be the main problem. If you do any exercises against gravity, it's going to cause a problem and potentially compromise the healing of the triceps. Seated active flexion and active extension. So if you're seated, active extension is gravity assisted, so that's probably not going to stress the triceps too much. Intermittent immobilization, once again, this is going to protect the elbow, including the triceps. So the main answer will be the prone extension against gravity. That's going to cause a problem with the triceps. Next simple question. 55-year-old woman develops a post-traumatic arthritis in the elbow following a distal humerus fracture. What is the most likely midterm, which is about 5 to 10 years after surgery, complication after semi-constrained total elbow arthroplasty? Bushing wear. That is a possibility. That is unfortunately when the bushings or the plastic between the prosthesis can wear out. Infection generally occurs earlier. Aseptic component loosening, that is a possibility as well. Component fracture is very unlikely. Wound dehiscence is mostly an early complication. So we're talking between bushing wear and aseptic component loosening. Generally, aseptic component loosening occurs somewhere after about 7 to 12 years, in that range. So in the 5 to 10 year term, most likely the bushing wear is the answer they're looking for. All right, good luck. Hopefully this makes some sense and was helpful for you guys. If there's any questions, just reach out to me directly.